right, first impression. Here we go. So my first impression, very red in the center, depressed, bit of chicken skinning around the outside. I think you can clearly see from here. I'm here with also Andrea Sorge from Milan in Italy. I mean, what would be your approach to this, Andrea, in terms of further characterization? Because I guess the question we want to get out there is, you see something like this in your endoscopy list, what's the next move?
So I think first of all, take a bird's eye view on the lesion, and try to include some anatomical landmarks in your
Nice.
brain.
So let's do that. That's
Yes.
very nice. So here we have, dentate line coming back on anal verge, and you can find the dentate line here. Not so easy to appreciate, but it's probably here, right?
Yeah.
Dentate line. And then if you just push in, use a cap, then you can appreciate the valves, right? So it's on which one, would you say?
I would say it's on the inferior piston valve.
Okay, so this one on the left, then this one on the right is the inferior, this one on the left is the middle,
Yes.
and the one in the distance is the superior.
Yes.
Okay, so that's where it's at. And then we got fluid here. So patient on the left lateral, there's fluid over here, and it's opposite the lesion. So what does that tell us about position of this, or does that help us?
This is important. I think we can say the lesion is located on the right wall, also a little bit on the posterior, like right.
And just to explain this to people, the reason why you're saying it's on the right is because the patient's on their left and the fluid's on the left.
Yes, it's on the contralateral wall compared to the fluid, and in this case, the fluid is on the left.
Okay.
So we can infer this is on the right. And actually, we felt it also to confirm it before with our finger, and this is true. So
it's true. And the posterior aspect of it versus anterior, how can we infer that from the position of the fluid, or is there another way that people need to think about that?
Yeah. I think the easier thing would be, but not in this case, to put the patient onto his back if you want to confirm, and you will see the water going to the posterior wall. But if you think at the image you're having as a CT scan image on the axial view, you can infer this is
infer the position. Okay, yeah. Nice explanation. And then final thing is, what relevance that has for this lesion? Why are we going on about that? Well, the relevance is in terms of resection, right? Because posterior is much safer to resect than anterior. Okay, but anyway, let's take a step back. So you talked about an overview. We've done that. I've given my opinion. What's the next move? I mean, say that you're someone who's not an expert. You want to provide as much information about this to a multidisciplinary meeting as possible.
So think of the blink features of cancer. Use them as a checklist. So you think of them, do you evaluate them, their presence in the lesion? In this case, we have discussed them. So extra redness, there is thick skin mucosa, there is a depression. So
three of them are present, right?
So these are suggestive of a lesion which is started to invade the mucosa, so is a cancer basically. So,
and I think actually more than that, they are suggestive of a deeply invasive lesion. So what do we mean? We mean that it's not just a little bit invaded, but it's deeply invaded, maybe against the muscle there. This is important in terms of choice of treatment. Okay, but so we've got that information, but do we want to think about further characterization and also probably distance from the anal verge? These are probably two other important things, right?
It is important, and needs to be also discriminated. The anal verge and the dentate line, they're not the same thing.
Okay.
The dentate line is the squamocolumnar junction, and it can be also appreciated in, I think, in retroflexion.
Yeah, absolutely.
Maybe better, but we saw it already. And also, I think BLI can help you to distinguish from the columnar from the squamous epithelium.
So here we go.
Yeah,
you see it nicely here. And so this is the dentate line.
Yes.
So where's the anal verge?
The anal verge is basically at the end of our endoscopy. Yes. So there are some centimeters of difference.
Of here, yeah.
Yes. If you start counting from the outside, you just look at the scope and you see the centimeters.
This is from the anal verge.
Yeah. And yes.
Okay, so we covered that nicely. So then we are looking, basically distance to the dentate line is probably the easiest to appreciate in the imaging, right?
Yes.
And so you can see squamous coming in here. And so what would you estimate that to be? Because my scope is now on it. It's difficult, isn't it?
It's for more or less for 5 centimeters.
So how can we measure it? Well, I guess
You can.
Yeah, it's not so easy, is it, with a flexible scope?
You can go right where the lesion is, put your fingers on the anal verge, pull back, and see the distance. So here, you really go there with the fingers, then pull back. And when the scope is out, you can see the distance you've done.
Yeah. And I think also another thing you can do is retro, like you said, right? And you can retro and get some sort of distance. I mean, because this we do all the time, right? And so you can clearly see it there. That's actually quite hard to retro on it, which is going to be some impact for our what we're going to do for this lesion. But you can appreciate it's kind of on the cap now, so it's relatively far from the dentate line and the anal verge. Okay. And then characterization, so a little bit of pressure on it now. If we turn this down a little bit.
So there is also maybe we can say there is spontaneous bleeding, because with minimal contact there is bleeding. This is another
another blink feature, for sure. Okay, can you turn up a little bit, Andrea, for me, the water jet, and then we can talk about magnified endoscopic imaging. Maybe a little bit more. So you can get beautiful images with water immersion. I think we are on one of zoom here on this 760Z endoscope. And if we freeze this, what do we see?
So we see really different areas with different characteristics. So I think there are areas where the vascular and the pit pattern is completely absent. So I would say genetic type 3. Agreed. And there are areas like the more reddish, where there is a pattern indeed, but it's irregular, so it's aberrant.
So I think this can be quite confusing to people, can't it? Because people, when we are talking about the whole, what is JNet? Well, it's basically about regularity, right? And then we say to people, oh, you look for a regular or an irregular pattern, right? People look at the bottom and they appreciate what you're saying, but they look at the top and they think, well, there isn't anything there, so maybe that's just normal. And I think it's very important what you've said, that it's almost amorphous there, isn't it? You can see the vascular pattern. I mean, they are there, but they are very spread out and all over the place, I think it's fair to say. Yeah. So that's that area, and then as we come up to the top, oops, fell off it. As we come up to the top, and now we're trashing the vascular pattern, but I still think you can see it if you have water pressure. Then there is another area up here of relatively preserved pattern.
We can really see how water with a zoom really increases our ability to say something about the lesion.
Yes, absolutely, because actually when you back off it, here we have another maybe bit more structural area up here. Anyway, when we back off it now, and we've used any kind of water immersion or anything, you get this kind of image. I think this is a lot of the time why people struggle. They struggle because they have this, and then they think, well, actually, I sucked onto it a bit maybe. So the technique to avoid that is turn the magnification off. Okay, we get some idea, right? But it was better before, because before we had no blood on it. And use water. And you have to have a cap, because if you don't have a cap, then you are in trouble. Okay, so I think that's actually a very useful overview. Anything else you wanted to add, Andrea?
I think that's basically all. So it is very important, if you can, to also take a video and for referral, either for the surgeon or to discuss it in a multidisciplinary meeting, or some really good images like the one we showed.
Yeah, I think that's critical. So let's summarize then, because we talked about distance from the verge, we talked about position, we talked about blink features, we talked about size. I didn't even think we did talk about. So size is also an important thing, right? And I think here we're talking about 20, that kind of size of lesion. And we talked about characterization and picking the worst zone. We talked about nice videos and nice images. Finally, two other things. One is biopsy, yes or no?
Well, this case is, I think, borderline towards surgery. So maybe you can before discussing it, maybe take a lot of pictures and a good video, discuss it, and then if it's for surgery, it's very easy to come back
at the end. It's different, I guess, than the rest of the colon.
Yes, yes.
And the final thing is other imaging. And I mean, I think that is relevant here, isn't it?
Yeah.
MRI,
Yes.
CT scan. You need to do these, and this patient has had both of those, and both of those, they don't show T2 disease and they don't show metastasis. So, okay, perfect. Well, thank you for watching. I hope that's useful. That's about how to characterize a rectal lesion for MDT discussion. Thanks.